We had an excellent time, and we do have more coming this afternoon. Our first speaker is going to be Professor Yifru. Professor Yifru is a medical specialist, gynae obs specialist, and especially trained in leadership and governance. Professor has more than 24 years of experience working as a clinician and university instructor, researcher with more than 100 publications, and a mentor for quite a lot of PhD and other students. And he is known for his public health leadership. He was a dean and vice president in Awasa University, and also in Addis Ababa University in a different time. And he was a former minister of Ministry of Health in Ethiopia. He has been engaged in different consultancy roles, both for national and especially academic institutions in the development of national strategies, guidelines, and different manuals. Currently, Professor Yifru works as a senior researcher and consultant at St. Paul Millennium Medical College, and he is currently working as editor of BMC Pregnancy and Childbirth, the postdoc and fellow research advisor and chairperson at EPHI, and he is board member for both Jimma University and Jimma Institute of Health, also technical advisor, part of technical advisory group for World Health Organization. It is privileged to have Professor Yifru. Unfortunately, Professor Yifru is not making it in person, so we do have a video pre-recorded presentation, and we'll go to that.
Good morning, everybody. The topic that I'm given to this morning's talk is on building a perioperative and acute care national research capacity, specifically on research impact, research challenges, and possibilities. I'll not be focusing specifically on acute care and perioperative care. I'll try to touch the overall research undertaking in Ethiopia. So this is my presentation outline. I'll not go to one by one here, and let me start with some introductory remark. In general, medical research in Ethiopia is still at grassroots level. Only limited number of professionals are engaged in doing research, and mainly this is for academic career development. And the articles that you may find online are mainly extracts of postgraduate student thesis, and our international collaboration is very limited, and the research outputs with good strengths of evidence are very low. This is despite the fact that medicine is an ever-changing science, and many of the academia may be engaged in clinical service provision and teaching. However, their engagement in research is not as such to what is expected. Therefore, faculty and healthcare workers need to teach and practice based on evidence, and this will be possible when they are engaged in research. No one will be up to date unless he is or she is engaged in research. This is what I believe. The research impact, well, it is clear, but just to highlight some of the points. Research findings with good strength of evidence is an original contribution to the existing stock of knowledge. It's vital evidence for policymakers and programmers, and it's an academic excellence, of course, for the institution and as well as for the researcher. it is clear that it is research and the technology what has changed the world. And the world some century back was quite different from what it's today. And this happened because of the technology and the research undertaking globally. It's the research what makes us even an active learner. So as science grows, and we grow also parallelly when we engage in research. When we do research, this is what my understanding is. When we do research, we read the world, and the world reads us. And in general, attaining excellence is possible by translating evidence into practice. Challenges is easy to talk, but difficult to solve. And particularly in low-income countries like Ethiopia, the challenges are a lot, and some maybe because of the mismanagement of resources, and some are actually due to scarcity of resources. The lack of researchers as a model and the supervisor may outweigh the resources, and because when people are working on research and then other projects, they are likely to mobilize resources. So the lack of good researchers is what is limiting our engagement. Laying the ethical clearance at the national level is another hurdle, and very, very challenging to have collaboration with international researchers and doing some impactful researches with those who have credible experience in research. So the national law that we have in this country is, I can say, not facilitating, rather blocking the type, particularly if the research is on randomized controlled trials involving children and pregnant women. It's almost impossible to do that kind of research. Whatever the trial is, even in the micronutrient supplementation, which is highly recommended, and which we have credible evidence from other countries. Therefore, limited experience in developing a competitive proposal for grants that we have, maybe another limiting factor. And these are some of the challenges what really limiting us not to engage in the research. What can be done? Well, there are many issues that can be solved at policy level and at the facility level, at the research institute level, and then the building a capacity of the researchers and conducting impactful researches may have maybe some of the solutions. So we have to also grow with the digital technology in terms of accessing as well as utilizing. It's not only for doing research, but also for teaching. The digital learning is becoming popular thanks to, may I say thanks to the COVID-19. So this is another important area we need to work hard. What can be done? Again, establishing research resource center is a very good solution in my assessment. This is a kind of unit well equipped with audio and IT facility. Each university needs to hire senior researchers who will be dedicated only for assisting junior researchers and postgraduate students. Therefore, they can assist researchers, junior researchers in proposal writing, accessing and utilizing electronic data and journals, data analysis, write-up and dissemination, that is up to the publication. So these are professionals who can make a difference in each university, what I but I think is possible. And another one is many of the academia have a difficulty in accessing or following some calls, and so hiring professionals will be assisting in grant writing, call hunting, and language editing. Definitely will improve this engagement in research. Establishing research resource center is also to support research training, manual development, and additionally engage in soliciting funds. There are local sources and as well as international sources, financial sources that can be utilized for research undertaking. Apology. Let me close this. And as part of the Research Resource Center, it is important actually to establish a research IT system for researchers that they can utilize to access data and also to conduct analysis. Another important thing is implementing the electronic medical recording for the researchers to have access to hospital and as well as community-based data is another important input that can make a difference in research undertaking. Assisting in improving the procurement process is another important milestone. Researchers usually complain because of the difficulty in getting the right time, the budget, and the right time liquidation, and also very difficult part of the procurement process that we have in this country is really a hindering factor. Building the research capacity through training and practice is another important thing that we need to carry out. This can be done by cultivating the local potential and exploring international opportunities to uplift the research capacity of faculty and postgraduate students. And it is not as such difficult to organize inductive trainings on grant writing, protocol development, management of primary data, and secondary data analysis. What's important is having an office that can mobilize such kind of activities and make a reality. Involving senior research co-advisors for postgraduate students from outside universities. This can be from the national resource, can be from international source. So this is another important point need to be considered to fill the gap. Promoting and supporting multidisciplinary problem-solving research projects, again, should include integrating basic science research with clinical research to the best. Public health, basic science, and the clinical research researchers has to work hand in hand, and this may be facilitated through, again, the Research Resource Center. Leveraging the technological resources for research. There are, these days, it's not in the old time. Technologies are advancing, and little effort may bring about a huge change. So what's important is engaging and uplifting the knowledge and the skill of the potential researchers. Another very simple but important is promoting systematic reviews and meta-analysis, whose cost is minimal, but their impact is global. As you know, the best evidence is meta-analysis of randomized clinical trials. So to have the best evidence, that is in terms of strength of the data, to have an impact on the programs and the policies, this is simple that we can do, and we can teach also researchers how to do it. Aligning and supporting the research works and the innovations with the national health and health-related priorities. Yeah, this is to support the national program, the health program. The Ministry of Health and Regional Health can utilize our research products, our research outcomes based on if you are interested and if we are engaged in their research priorities. Creating an international research link and a collaboration to conduct highly impactful primary researches. Yes, learning from others and evolving others and making it a collaborative type of research. Yeah, that is what the world is doing. And many developing countries, that's the kind of experience they have. But here, because of the national law, our engagement is very limited. Therefore, to establish a triangular research partnership like South-North collaboration, and this will be evaluated as a good collaboration, and likelihood of winning international grants is very high. And giving a special emphasis to sustainable collaborative research projects. That's how universities grow. There is no university in the world that becomes renowned without having such sustainable research projects. So this is how our university should also grow. Integrating research ecosystem. This is by collaborating across disciplines within the university, and the external partners, and involving stakeholders and communities as well. It's also important to integrate the postgraduate research with the staff research and the thematic research areas. Everybody is doing little alone, not collaboratively or jointly. So this kind of efforts are not as such fruitful and may not take us anywhere. So to have an impactful research and to make a difference in our research endeavors should be integrated type. Developing research projects, enabling developing several daughter protocols is such an outcome. When a research project is longitudinal type, and that can have multiple daughter protocols and multiple research outcomes, I think that's where we're lacking. Establishing a core research lab that can serve for all. Every basic science researchers are doing their best by establishing a standalone research lab. This is not good. Rather, having a core research lab may serve for others and help us to do more and jointly. Abridging the bureaucracy in health research for postgraduate students. This is clear and may take time, but whatever the case, that's where we need to act. Directing postgraduate students to focus on the university's research thematic areas. I think this is a strategy, should be the strategy, and should be taken seriously. Still, with all these facilities and inputs, if researchers are, particularly academia are not engaged in research, I think this is a time to implement the publish or perish rule. Every university developed legislation, and in every university legislation I have reviewed, found that this publish or perish rule is there, but it's not implemented. So let's create a favorable research environment in the hospital as well as in the community to academic staff, to let them intensively engage in research by establishing a resource center, applying the 40-40-20 working time allocation. This is what it means, is 40% for clinical service, 40% for teaching, and 20% for research. This is equivalent to around 53 days in a year. That's a lot. That's a lot. As somebody who will be engaged in, this is in the legislation, by the way, this 40-40-20. And if somebody is given this number of days as per the legislation, why not is able to, or she is able to produce 2 to 3 articles at least in a year, if not more than that. So if he or she failed to do that, there is room again, up to 8 years, if somebody could not promote from lecturer to assistant, from assistant to associate professor, from associate professor to full professor, this period, that person has to be warned, should be given a letter of warning. And if he couldn't do it, this time, the contract has to be terminated as per the Senate legislation. One more undertaking that can be done at the national level is formulating a national research law. First one is giving a full mandate to universities for ethical clearance and follow-up. Currently, any research that involves 2 or more researchers, 2 or more countries as researchers, the ethical clearance is from the national body. And any clinical trial, be it locally generated or collaborated with international researchers, again needs national ethical clearance. Imagine in a country where 115 million people and more than 50 universities are operating, how is it possible to have such kind of ethical clearance as soon as possible? That's why ethical clearance is taking 6 months up to 2 years. This is blocking my assessment. This is what has been observed in the last decade in particular. Therefore, universities should be mandated to have to give an ethical clearance as they have owned their own, as they owned a strong institutional board. Second one is developing a differential financial management for research. This is a headache. This is a headache for many of the researchers because of the lengthy and very bureaucratic financial management. Researchers are not interested to get engaged. And therefore, last one is mandating universities to establish linkage with universities abroad and to collaborate. They have to be mandated again. As a strategic move at the university level, maybe developing strategic plan for research, bringing the importance of research to the attention of the academic staff, and setting and supporting research priorities can be considered. I'd like to summarize my presentation with this schematic figure. This is these are all my ideas. What I believe is, without big mind, there is no big country. Without big academic institution, no big mind. And without big research, no big academic institution. Without big international grant, no big research. Without motivated faculty, no big grant. Without good leadership, no motivated faculty, and without good strategic plan, no good leadership. That's how I see the interlinking or the interconnection of the policy with research undertaking. Thank you very much. Apology for failing to respond to your questions. and have a great day. Thank you.
I thank you, Professor Ifru. So as you just saw on the video, he is not able to join us, and the questions, reflections you have, we will try to entertain among the participants. If you have questions or discussion points, please put them in the chat box while we are having the next speaker. And at the end of the next speakers, we will try to entertain all those. And possibly from Ministry of Health or any academic institutions, Professor Ifru has raised a very significant challenge that that should be addressed, and if anyone would like to possibly address some of the issues he raised, the possible or the future progress that could happen and all that, then we will come back to this discussion if we get any response. Our next speaker is Professor Bruce, and I'm not going to introduce him. He was introduced in the morning. Professor, the floor is yours.
Right. Afternoon, everyone. FITSM and the N4PCC have asked me to talk about this topic, the experience we've had from ASOS and ACOS, and the need to develop African acute care collaborative research capacity. So in this talk, it's really two parts. Firstly, just talking about the experiences of ASOS and ACOS, and the sort of points I want to raise are that generosity goes a long way, that we have the capacity to do large-scale, high-quality research, that the global community actually cares about us in Africa, and we care about Africa, and then finally, why there is a need for acute care collaborative research in Africa. I've discussed the funding of all the research this morning. So firstly, just a quick note about generosity and what it can generate. So I think a lot of what we're talking about today is through the generosity of Rupert Pearce. I was fortunate enough to be at a meeting in London. It's quite a long time ago now, when Rupert presented the data for USOS, the European Surgical Outcomes Study. And the simplicity of the work and the pragmatism was very attractive to me. And I didn't know Rupert at the time. I contacted him and I said, I really like the work. I really would like to be able to replicate it in South Africa. And he basically shared all the resources with me, even provided a database for us to help us run the study in South Africa, and that was called SASOS, South African Surgical Outcome Studies. And from that came ASOS subsequently, and the future work. And really that was just through pure generosity, and not knowing me at all or knowing any of us. And it was that generosity which is, I believe, led to where we are now. So just thank you to Rupert. The second thing is, I do believe we have the capacity to do large-scale, high-quality research, and I'm going to give you some examples. So when we did ASOS, the first project, we recruited over 11,000 patients, 247 hospitals across Africa from 25 countries. This was basically established cold from a network at that time which didn't exist. We look at ASOS 2. This was conducted over a year between May 2019 and July 2020. In SOS2, 28 African countries, nearly 29,000 patients were recruited into a clinical trial and 332 hospitals. If we look at ACOS, the African COVID-19 Critical Care Outcomes Study, 10 countries, so this is in the pandemic, 10 countries, 64 hospitals, over 3,000 critical care patients. If you put these three projects together, as a group, we've recruited over 43,000 patients into collaborative studies, which essentially have been unfunded. If you look at the countries that have participated, so far in the three studies, 33 countries, and at the moment with SOS-Beads and confirmed countries, at the moment, you could say the network is now 38 countries with the inclusion of countries such as Liberia and Somaliland as well, which is extremely exciting, I think, for the network. I just want to highlight ACOS and our capacity. So considering that this is in a pandemic, we recruited over 3,000 critical care COVID-19 patients. At the same time, we did a meta-analysis to put our data in context. These are all the studies that are, at the time, provided definitive COVID-19 critical care outcomes. What I want to point out that the work by ACOS was the fourth largest cohort of any study published. That's the first thing. And the only continent that provided the three bigger cohorts was Europe. In other words, our work exceeded all the other continents, including North America. So, I mean, I think this is a phenomenal work by the group. The next point I want to make is that the global community cares about Africa. So let's look at just some of the startling findings we've had in the work we've done. So the first is on the number of specialists or the workforce density. 20 to 40, as I said this morning, per 100,000 is the recommended minimum standard. ASOS shows us it's less than 1 in Africa. The second thing we know is if you have surgery in Africa, you're twice as likely to die. The third thing is that we know when you look at failure to rescue, death following complications of surgery, twice that of the global average. You look at failure to rescue in a more acute situation in obstetrics or cesarean deliveries. If we look there, what we see is that the complications are about 2.5-fold in the African cohort compared to the US. And when you look at the mortality, it's 50 times higher in Africa. So if we look at failure to rescue for adult surgeries in Africa is about twice the global average. If we look at cesarean sections where the mortality is 50 times and the complications is about 2.5 times the US, failure to rescue following cesarean deliveries in Africa is 20 times higher than that of a high-income country. And I think what this speaks to is how devastating failure to rescue is when there are acute complications such as bleeding. Also wanted to look at the findings of ACOS. So in ACOS, when we did the meta-analysis, what we saw is that the mortality for COVID-19 critical care admissions globally was running at about 31 per 100 admissions. When you look in Africa, our mortality was running at nearly 49 per 100 admissions. 1 in every 2 that's admitted died. This is an excess mortality of nearly 20 deaths per 100 admissions to critical care. Then you look at the resources in critical care. I think for me, the most striking is that in a critical care environment in Africa and in the sites that participated, so we would assume these are very well capacitated sites because they could participate in the study. Only about 8 or 9 of every 10 patients in the critical care has pulse oximetry. I mean, the resources are clearly totally inadequate. And then when we estimated, therapeutic interventions such as dialysis and ECMO, we estimated that the provision was about 7 to 14-fold less than one would expect for the severity of the disease in Africa. Why do I say the global community cares about Africa? Well, you look at all those results and they're distressing. Not once has anyone spoken out badly about the results or pointed fingers at us. In fact, the global community have been very supportive of the data we have presented. In fact, they've even shown their support. So the evidence-based perioperative medicine group, what they did is they ran a fundraising initiative for APOC at their last World Congress last year. And it was through donations of delegates to this meeting that they raised the money, which has now become the African Perioperative Network database, which I've been telling you about, and the QR code that you can see on the screen now. So certainly what we're doing, the global community believes in and cares about. The next thing is, I think what our research shows is how much we care about Africa. So if you look at ASOS, after ASOS, we asked clinician researchers who participated in ASOS, would they participate again? Now, I just want to put it in context. So the first thing is, we know these are people working across the continent where there's less than one specialist per 100,000 surgical operations. Sorry, less than one specialist per 100,000 population, 20 to 50 times less than the recommended minimum. So they're providing a service in a very austere environment. The second thing is, there's very little research capacity, and most of these people do not have any research assistance, and the research is unfunded. And I think this is the most astounding responses that you get. Did you find participation in ASOS valuable? 9 out of 10, yes. Would you participate in similar research in the future? 9 out of 10, yes. Can your hospital participate in future unfunded studies? 9 out of 10, yes. It's a very powerful, positive response from clinician researchers in Africa. And then the free text responses in that survey also offered a lot of insight. By my participation, I want to help my continent. ASOS served as an eye-opener to the possibilities and benefits of interdisciplinary and multinational research. I love collaborative research, and only Africans can tell the African story. What about our response to the findings of ASOS? So we know that we got limited healthcare providers. We know our mortality is twice that of the global average. We know that nearly all these deaths occur post-operatively, and there's a large proportion which is due to failure to rescue. So what we did is we thought if we can, so I suppose the first thing is most of us were astounded, and we could not actually accept the excess death that we knew was happening. So in a quick response, we thought if we could reallocate human resources to those at a higher risk and increase post-operative surveillance for those patients, we may decrease failure to rescue and perioperative mortality. So a study design was set up, extremely pragmatic and massive sample size, because we knew following patients once they leave the hospital is impossible. And we also knew verifying outcomes besides death are extremely difficult in a low resource environment and unfunded environment. So huge sample size for in-hospital mortality. And we delivered that trial. And what we know now is that with the work we've done before, that there really is a massive need for acute care collaborative research in Africa. So if you look at ASOS2, so the trial was conducted, and unfortunately there was no difference in post-operative mortality between the intervention group and the standard of care group. But we know failure to rescue is a problem, twice that of the global average in adults, and 20 times that of high-income countries in women who have a cesarean delivery. And if you look at the process evaluation for ASOS2, we made two assumptions. We made the assumption that if we allocated a increased surveillance appropriately, in other words, to those who are more high risk than low risk, that we wouldn't increase the burden of work on the healthcare providers. And the second assumption we made is that we would be able to detect earlier complications in these high-risk patients before they went on to death, and we would be able to escalate the care and provide timeous interventions. So that was the program theory. So then why could we not show benefit? So in reality, from the trial, we can't determine whether the intervention arm received more post-op care. We can't determine whether we identified complications earlier, nor can we determine whether the escalation of care was appropriate for the complications. Similarly, we can't determine if there was co-intervention in the standard of care arm, because in ASOS, the mortality was 2.1%, and in ASOS2, the standard of care mortality was 1.3%. And then when we look at implementation fidelity and the fidelity of conducting the intervention in the trial, we find that there were other factors which were contributing to its fidelity, and these included teamwork and leadership, and also running dummy runs or testing the intervention before the study. Another finding is that in the critical care environment in Africa, we really don't appear to have sufficient resources to respond to acute deterioration. And again, I just want to highlight the point that, you know, in a critical care environment, if only 8 out of 10 patients have a pulse oximeter, this is really far from appropriate. So the question is, certainly there's a signal of failure to rescue. There's a signal of increased mortality. There's a signal that failure to rescue is worse in the more acute complications, such as we see in cesarean deliveries and in critical care. And so really, is there a need for quality improvement work in this space? Do we carry on and try and provide enhanced post-operative surveillance from a quality improvement implementation project? So the 3 questions, I think, is, should we do it? Is it important? And how would we do it? Should we do it? Certainly. Because we know mortality is twice that of the global average. We know failure to rescue is twice that of the global average. And we know almost all the deaths are occurring in this post-op period where the complications occur. Is it important? Well, as a group, we certainly believe it's important. So in the process evaluation, we asked all the hospital leaders a whole lot of questions. And the question that got the highest positive response was the following. I predict that the ASOS2 interventions will be effective for reducing post-op mortality in my setting. In other words, the participating hospitals in ASOS2, 332 of them, believe that increasing or enhancing post-operative surveillance is a very important intervention to decrease failure to rescue. How would we do it? The data suggests from the process evaluation that if we want to improve outcomes in Africa in these acute conditions, in fact, they are complex and they need quality improvement projects. And this is sort of where we are now, looking at ASOS QI and trying to develop it for a QI project for enhancing post-operative surveillance. So in conclusion, I think our data shows quite clearly that there's a need for acute care collaborative research in Africa. And I think we also definitely have the capacity to respond to this need and develop the high quality research that's needed. Thank you.
Professor, participants can ask question now, and we will entertain questions. You can raise your hand, and if necessary, you can just unmute yourself and speak. While waiting for participant, Professor, I do have a question. Thank you for a very excellent presentation. My question is, so you mentioned we do have lots of problem at our hand from just this study where we have enough evidence saying there is much going on, and quality improvement is going to be the best solution we have. And I'm just curious about the project, the quality improvement project your team is designing. How are you planning to integrate with national previous efforts? Like most of the country, I believe, will have this quality improvement concept. They do have as a national plan or a strategy. And how do you plan to integrate this project with the national efforts?
Thanks, Helu. So, Helu, on the perioperative network database, what we want to, once one goes in there, all the projects are loaded, and we've asked people to indicate interest in the quality improvement project. So they're individuals and sites from a number of countries who have already indicated interest. So it's basically like a two-stage process. The first being a pilot development phase on quality improvement and implementation, and the idea that participating pilot sites work locally with the concept of one, do the sites believe in the hypothesis In other words, so there's an educational and common vision initial part, which is, do we believe that most deaths are occurring in the post-op period because of failure to rescue? And once, if that educational component is agreed upon, then moving towards what are the processes which are driving this failure to rescue and mortality, and then how can we address it at the local site, and in embedding processes of care which ensure that there's early identification, that there's appropriate intervention and appropriate care of the patients. So, and the idea is to build multidisciplinary teams, because that came through also in the process evaluation, and in the few successful implementation programs in the literature, in the sort of surgical literature in low and middle income countries, certainly multidisciplinary care teams are important, and this is what you're talking about. And it's about nurses, doctors, administrators, managers, and I think it does talk to your point about if they're already established quality improvement teams, either within a hospital or within a country, it would be fantastic to have them on board in that process, because ultimately these, it appears that most of these projects fail if the team fails. So you can set up a beautiful project in a well-resourced environment, and it can still fail. And I know Rupert is on the call, but one of the real classic, I think, examples is EPOC, which was the NHS quality improvement project for emergency laparotomies. It really is a fantastic project. All this best practice for pre-intra and post-op care, yet 90-day mortality did not change. And the process evaluation, a lot of it comes down to things about leadership, teamwork, audit and data presentation, and how it's communicated. So certainly, yes, countries and hospitals with well-established QI projects or teams would be very beneficial in this pilot stage. And then if, through the pilot stage, if we can show proof of concept through these different teams in the hospitals, and then take common principles and try and put a package of care together, or packages of care together, to propose for Africa, and then test it at a continental level. That's the plan. Does that, Haley, I'm interested to hear your thoughts. Would you agree with that?
Yes, that is actually what I'm thinking. I mean, the concern is like when it comes to quality improvement, usually with different project comes a different innovative idea. There is this sort of pseudo innovations around quality improvement, and in my experience in Ethiopia, different partners get to involve in quality improvement projects, especially concentrating in a different it could be maternal and child care, it could be surgical, it could be whatever programs that organization engaged in. And with that comes like different thinking, different model. And those models, when they reach the ground, it usually end up confusing the frontline workers, having a different language, having a different implementation mechanism. And that is just my concern, because it is wise to channel every project that comes through what is existing nationally. That existing system might not be strong, existing system might not be functioning to the extent we want it, but ultimately to what you said, whatever novel idea we have, it is going to fail if we don't actually work on the implementation through the team. So yeah, that is my thinking, and it is really wise to go through whatever fragmented effort that exists in each country.
That's very helpful. Thank you, Adi.
Yeah, I don't see any question. Maybe I don't see on chat, and there is no on YouTube as well. Maybe if I may, I would ask one last question,
Sure.
then we would shift to the next speaker. Okay, somebody raised, and I think we'll give that chance.
So that's Lemlem. How about the strategies to maintain the sustainability of QI projects? Yeah, thanks for the question. It's a very difficult question, especially being at the beginning of the process and not towards the back end of the process. So the first is, I suppose, the reason I find it difficult, because I'm not even sure. I imagine the QI project is going to be quite, it's going to be the biggest project we've ever tried. It's going to take a lot of work. It's going to take a very different strategy. You know, the work we've done to this point is predominantly quantitative, and now we're going into the field of qualitative work as well, with a quantitative element, and also about QI projects in our environment are going to each, like Haley was discussing, each site will look different. So it's how do you develop a quality improvement project which is broadly generalizable, but at the same time totally unique to the site where it's been implemented. And so to do all that and show that maybe we can improve the quality of care, only after that will we know if we can sustain the project or can address the issue of can we sustain the project. So I can only talk from a theoretical perspective. Again, looking at all the literature on successful surgical implementation projects in low middle income countries, the data is actually very limited. The ones which have shown what they call sustainability, they've only had sustainability in the 3 to 6 month period. I think what we have to accept is once you go down this road, it's not something that you go in, do it and leave. This has to become a culture for the environment in which we provide care. In other words, if we believe most of the deaths are happening in the post-op period, and a lot of it is happening because patients, their complications are progressing, eventually the culture must be that we routinely audit the outcomes in the post-op period, and we audit the processes associated with ensuring that we are identifying patients who are deteriorating early, audit the processes that the interventions offered to these patients are appropriate for the complications. And once that is part of the culture and the ethos of where we work, it has to be maintained. And that comes to the next part of the importance of us establishing, you know, at the very beginning now, a very simple perioperative mortality database across the continent, where we got very simple risk factors. So we can, at the same time, track what's happening in our hospitals. We can also risk adjust appropriately what's happening in our hospitals. And then we can see the effects of what we're doing also at a hospital level. So it's a complicated story, but I think when one thinks about sustainability, I believe the only way this will be sustainable is by creating a culture of continually doing the implementation work which has been shown to change outcome. And reflecting on processes and outcomes will also mean that we will refine the processes as we go along so that they remain appropriate to improving the outcomes of the patients. Does that make sense?
Thank you. I think we do have another question.
Yes, thank you, Bruce, and hi, Lou. Very good points. It's Luigi here representing Critical Care Africa Network. So much learning for other networks. I mean, the work you've done is massive and unfunded. That's really tremendous. Just wanted to ask you, what do you think is a message for the critical care and ICU research community in Africa? Are large multi-center, multinational trials on quality improvement initiatives a way, or should we focus on different designs? What are your inputs?
Okay. Thanks, Luigi. Okay, the first thing is I'm not an expert in critical care, but there are lots of experts on this group, I know. But my feeling is, I'll tell you my philosophy. So the biggest problem we've got is that we know the outcomes are bad for so many different reasons, but I mean, driven predominantly by a lack of resources. And the amount of funding we have is small. And so I think we have to go for big wins, which are simple and generalizable. My advice is, what are the easy things we can do which generalizably will make a big difference at a population level and are easy to implement? So if you just use, I mean, if we just go back to the surgical sort of understanding we've got from ASOS, is that we know most of the deaths are in the post-op period. So that's where if we in that space, that's where we need to focus. And also because we know we can get access to the patients there. The second thing is we need to look at really simple things to change the outcome. And so the whole concept of failure to rescue and post-operative surveillance is a very simple one. But really, the biggest learning we had is, unfortunately, it's not like giving a drug. It's not like giving an antibiotic and the patient will be better, or giving a beta blocker and the ischemia will stop. Which has shown us actually that it's quality improvement. But I still think the principle is important. And so, but there's so much heterogeneity across our systems, but we're all ultimately dealing with the same problem, in that we don't have enough physical resources and we don't have enough human resources, and that the patients present predominantly late, unfortunately. So I think that is consistent. So we have to look at general principles which could be applied. And I'm sure in the critical care environment, it's exactly the same there, that there must be some very simple things one can do to make a change, which theoretically would have a very big impact generally. And so my principle has always been about generalizable change. And that's what I would advocate.
Thanks, Bruce. Very, very good. Happy to brainstorm further with everyone on this call. The intervention is not so easy to define, but a lot of learning from you guys. Thanks a lot.
I think, you know, all the work that's been done with the EECC group, which I presume you are one of the key people there. That, you know, that's a big network, done really good work, set some really good standards, and really a great place to start. And another thing that we also did quite early was engage the network in trying to find out what people thought were research priorities. And I think asking, you know, a big network like that, where do you think the low-hanging fruits are? How are we going to address these low-hanging fruits so we can provide a generalizable intervention would be a good place.